Hello, everybody, again. I am Dr. Neil Paulvin. Welcome to another episode of the Life Optimized podcast, where we talk about optimizing health, brain, exercise, and mindset. And today we have a great guest. We have Tim Schlidt from Palo Santo, and we are going to be talking about doing a deep dive and doing also some introduction, I guess, first into psychedelics, which have become huge in terms of the clinical side, trying to explain to patients how they can use them to help themselves, and also on the investment side, where you come in, and they're now, like a lot of other things in medicine, they are now merging. So we're going to talk all about that today. And you can follow us on all podcast apps like Spotify and Apple Podcasts. Also follow me on the Dr. Paulvin YouTube, and all these podcasts will be on there as well with the show notes. So Tim, let everybody know who you are as you you're both sides of the fence. You know about psychedelics and medical perspective, but also how this has become a rat race on the investment side. So let's everybody know who you are, and then we'll get into it.
Yeah. I'll give a quick intro and maybe a little bit of a genesis story too, just for some context on things. But as you mentioned, I'm a partner and co-founder of Palo Santo. So we're a venture capital fund focused on investing in largely the therapeutic applications of psychedelics. So that's largely what we focus on. And maybe just a bit of background on kind of how Palo Santo came to be. But it really started actually in 8th grade for me when I suffered from debilitating depression back then. I mean, it was like the lost year of my life. And so eventually got better, like things recovered, but that always left an indelible imprint on me for my whole life and developed my fascination for psychiatry, psychology, all things around mental health. So fast forward quite a few years in the future, had been through a career in finance, focused on healthcare though, and it's 2018. And I start seeing all these studies emerging out of academia largely, but around the therapeutic applications of psychedelics for treating mental health disorders. And I was like a total square in high school, college, never touched these things. So there's definitely this like fascination when you see the headlines or you read the papers. You're like, wait a second, somebody takes mushrooms and then they're in long-term remission for their depression. Like that's just very captivating. So that took me down a rabbit hole. Became very convinced that there is a therapeutic benefit here. And when done under supervision by a trained clinician, these can be really powerful tools. So, of course, tried them myself. It was an incredibly profound and shifting experience and shifting for the better. And then fast forward, there wasn't a lot of capital available in the space. This was around 2020. It was still an anathema topic. And there was really need for contrarian capital to invest and seed kind of the beginnings of this fledgling industry. So we launched Palo Santo. We've been around for about 3 years now. It's been an exciting journey. And yeah, we invest a lot in kind of the hard, high science in the space and can speak a lot to the pharmacology mechanisms, you name it. But yeah.
I am going to emphasize this now, so as kind of the underlying theme for the rest of the podcast. If you are going to indulge in psychedelics, they do have numerous health benefits if done the right way. So definitely encourage everybody, if it's doing for mental health or immune or relaxation, definitely work with either an expert healthcare provider or somebody who's an expert. We call them guide or guide leaders who can do on some type of expedition. Don't try to learn how to do them yourself, because they can have some pretty deleterious side effects if done incorrectly, or you have poor quality psychedelics. That's there. Let's go. So you mentioned the big topic where the rage into psychedelics kind of started, which is the mental health space. So explain to people which are the most common ones that we're seeing being used now. And I know they're being used for depression, PTSD. The data is coming out more and more and showing that there is some really good efficacious data out there now.
Yeah. So just to kind of go through the laundry list of psychedelics, because there's a lot out there, and there's some of the well-known ones and then kind of some more esoteric ones as well. But I think I'll start by like kind of the broad buckets of psychedelics. I mean, there's what are called traditional psychedelics, kind of the conventional ones. So we're talking psilocybin, LSD, DMT, 5-MeO-DMT, mescaline, which is the main constituent in peyote or San Pedro. And the reason they're called traditional psychedelics is they hit a specific serotonin receptor known as the 5-HT2A receptor. So there's 14 serotonin receptor subtypes, but the one that we think mediates therapeutic benefit as well as the hallucinations is largely the 5-HT2A receptor. So that's kind of the like purest definition would be those psychedelics, but I'd say the definition psychedelic, as we all know, gets used pretty loosely. So in the same conversations, people will talk about MDMA, which mechanistically is very, very different in a lot of ways. It's still serotonergic, but in this case, your body's kind of releasing its own endogenous serotonin rather than having a molecule mimicking the serotonin molecule. So there's MDMA. Ketamine gets used a lot in psychedelic conversations, even though it's really more like an anesthetic technically, and hits a totally different receptor, the NMDA receptor, and it really mediates more glutamate activity. So it kind of glutamate's an excitatory neurotransmitter. It tampers kind of that excitedness in the brain. And then the last ones I'll mention really quickly. Ibogaine is a really interesting one. It's this super dirty molecule. Nobody really knows how to classify it because it hits kappa opioid. It probably hits 5-HT2A. Probably hits even NMDA. It hits a ton of different receptors, but super effective for treating opioid use disorder in particular. Definitely hallucinogenic though. Definitely, you're in an altered state on that one. And then I feel like sometimes kratom enthusiasts kind of like there's this Venn diagram.
Talk about muddy. Is it the muddiest of all the psychedelics. Let's take a really quick step back because we did a deep dive there. So that's for people who aren't as familiar with some of the terminology. So we've talked some of the molecules and that Tim was talking about are what are called neurotransmitters. Talking about serotonin. Most people understand there's multiple different receptor sites which produce different things. They can affect everything from migraine. They can also again help your mood. That's where SSRIs came in, things like Prozac, and that's where they're initially linked to mood. And so these are produce the chemical neurotransmitter serotonin. We have dopamine, which is another mood booster. You mentioned MDA and glutamate, which can either be good or it can be bad if it's too much and you get brain inflammation. So these are all chemicals in the brain that can be induced everything from good things like exercise, sex, even food, and bad things like smoking and alcohol. And now they're now learning how to use psychedelics to target these very specific receptors to get the good and hopefully not get the bad parts of it in terms of everything from addiction to the hangover to you may like the psychedelic effect, but you don't want to be a zombie for days either. It's kind of like cooking in the kitchen and getting things exactly the way you want it to do and get the right effect. So in terms of mental health now, if I'm a patient coming in looking how to utilize these products, figure out what's best for me. I mean, right now it looks like I'm going to be talking to a psychiatrist who's adept and knowledgeable in terms of how to kind of, again, which tool do I need for me right now? Because some work, again, depends on what your diagnosis is. And then B, and I always tell my patients, you have to understand for a lot of these are not like an antibiotic. Okay, you take it and you're done. This is something you're going to be on a journey for a period of time. So how does somebody approach this when they're talking to their healthcare provider or whoever they're going to be working with?
Yeah. Well, I think first and foremost, healthcare provider is going to be limited to what's currently legal.
That's my next question. Yeah.
Yeah. So they'll be limited to that. I mean, the first stage certainly starts with diagnosis. So being diagnosed with a mental health disorder, typically, I mean, there's a gray area if someone wants to use something off-label, for example. I mean, there's certainly talk around cognitive enhancement and spiritual exploration, those sorts of things. You can probably pay out of pocket. Insurance is definitely not going to cover that. But first stage is diagnosis in terms of kind of what's currently on the market, what's legal in the U.S. right now. Well, we know ketamine is used off-label pretty ubiquitously. So that one's definitely out there. But like I mentioned, off-label, it is technically not. The study hasn't been done on racemic ketamine around depression. With that said, Janssen, so, Johnson & Johnson has S-ketamine. So ketamine's a chiral molecule. There's a right hand and a left hand version, what we call enantiomers. And so they've taken the S enantiomer of it, and that is indicated for depression. And if I'm not mistaken, acute suicidal ideation as well. So Spravato, it's nasal spray. So people can certainly use that. It's covered by insurance. So those are kind of the big ones. I mean, a lot of people go, I have to probably be a little careful what I say here and recommend. People will go outside the U.S. There are jurisdictions.
I mean, we put it all over.
Yeah.
Medical tourism is here and it's not going away.
All right. That's the reality. Exactly. I've definitely accepted it. And that's been, kind of the way I've utilized, gone and utilized things like psilocybin. But exactly. There's certain jurisdictions where psilocybin's legal or it's largely decriminalized. Even in the U.S., Oregon and Colorado have legalized really, but under certain kind of pretty strict guidelines in terms of how they're used. And then even in Mexico, I mean, ibogaine, 5-MeO, DMT, some of the more esoteric ones, those are uses allowed.
There,
well.
Costa Rica,
Peru, Brazil.
It's much broader. It's much more accepted part of culture than, I think most healthcare advances take forever. Longer in the U.S. probably than almost any other country in the world. I think the guesstimate is usually 17 to 20 years, which is not a good thing. But that's a whole other conversation for another day. A lot of different things intertwined. So in what formulations are people getting? Are these mostly going to be smoked? Are these going to be IV? People know that ketamine's an IV, but like you said, it's ketamine, the one that is traditionally now allowed to be used as a nose spray. So what formulations? So some people don't want to do injections. Some people don't want to do an IV. What formulations are out there? I know there's different formulations coming down the pipe.
Yeah.
Where are we at with all that?
Yeah, it's a good question. I mean, I'll start with ketamine, just kind of in terms of what's on the market. So yeah, nose spray in the case of Spravato or even racemic ketamine, we're seeing nose sprays. People can take it orally as well. I mean, there's lozenges, so, they dissolve in the mouth and some goes through the mucosa as well as just kind of, absorb through the gut as well. Bioavailability on that can be pretty poor. That's why sometimes people like to do IV or intramuscular for ketamine. But with that said, the route of delivery can really change the pharmacokinetics, and that subjectively the experience can change quite a bit from getting shot out of a cannon to kind of a gradual buildup into, maybe a gentler trip in some cases. A lot of what's coming down the pike clinically, and maybe we can hit on that of sort of what's in the clinic, and we'll probably, assuming, if they get FDA approved, what'll hit the market over the coming years, a lot of it's per oral delivery. So it'll be, you take a pill of psilocybin or whatever the API is that's getting developed, MDMA, same case, and kind of wait for it to onset. That's a lot, but there are, a lot of exploration, other folks working with DMT in nasal spray form as well. There's a company, GH Research, right now, which it appears that they will still vaporize. That's 5-MeO DMT. We thought they changed the delivery format, but it's looking like they're sticking with it, where it'll actually be a volcano vaporizer. So a lot of ways to get these into the body.
Volcano vaporizer?
Yeah, like the old, like what they used to use in cannabis.
Oh, okay.
It's like, yeah, it's the big, you've got like the volcano and then like the big plastic bag. And yeah, you vaporize it and then inhale it, basically.
You're in an interesting space because you understand the medical down to the pharmacology of it, and also you're on the investment side. And you brought it up a couple of times, so we might as well hit it head on at this point. So we have all these different companies. I mean, I forgot the number was probably right around when COVID started. It was a huge run on all these different companies starting to make product. Huge investment. I know now I saw a study like in the last couple months, investment has plummeted. A lot of the companies have either been merged or bought out, and it's kind of become a survival of the fittest. So how does the lack of approval in the U.S., you said there's 4 or 5 states now in the U.S.?
There's 2 that are kind of, it's legal, and then there's a lot of jurisdictions where it's decriminalized, but it's still illegal. It's just, it's like the lowest priority of law enforcement, but you can't create a commercial market in a decriminalized market. Yeah.
So how in your head do you kind of take the fact that the medicines, we know these medicines work. There's studies that show that they work. There's all these different companies that are looking for investment saying, hey, we have the next cool nose spray or pill so people don't have to go to the office and get an IV. And then there's the big overhanging, the state government's not wanting to approve it. And then, of course, the FDA and the big bad FDA there. So how do you feel how do you kind of put all those pieces together to make it rational to invest in it, knowing that this is not an antibiotic where you can get to market? How do you kind of put all those pieces together and just say, let's do this, and then this is probably the best company or companies to get me there?
Yeah, it's a good question, and I think kind of speaks to a lot of our philosophy at Palo Santo of like where we direct investment and what we focus on. So we've, as a fund, we've really focused on the biotech market. So, viewing these as therapeutics rather than, if you look at the recreational side of things, like cannabis is still on a 25-year journey to get, we're not federally legal, and there's still, there's a lot of states that have legalized it, but there's a lot that still aren't. So, and it's just this messy patchwork of regulation. So while it seems attractive that it's like a more direct to market type approach, it takes a long time, referendum based. It's very, very slow. Whereas on the biotech side, as you mentioned, you're running up against the FDA, so you're dealing with that. It's incredibly expensive. But the nice thing is, even if something is Schedule 1, if you get FDA approval, it is then by definition rescheduled because you found a medical use case, so it doesn't meet the Schedule 1 definition anymore. And there's a lot of drugs where this has been the case, whether it's Jazz Pharma, Xyrem, which is really just GHB at the end of the day. There's Epidiolex, which is like CBD, but at a time when, remember CBD was like synonymous with THC. Now, people have toned down the dialogue around that. There's Marinol. I mean, there's a long list of stuff, even cannabis-like products that have gotten FDA approval as medicines, and they can be legally prescribed. So that's what we're focused on. But as you mentioned, it's a much more expensive endeavor. It requires a lot of upfront investment to run large clinical trials. And so people want to see a payoff on the back end. And so what we're focused on, and I think the big sticking point and where you've kind of seen some of the implosion in psychedelics, is this issue around commercial tractability. Like the stuff that's really long duration where you need therapist oversight for 6 hours, it's going to take a very long time, be very expensive, dubious as to whether payers, insurers will cover that. And so there's all these rate limiting factors in terms of how it rolls out. So you're really only it's the top 1% who will be able to pay for that out of pocket and access it. So what we're focused on is what are the therapies that are much more commercially tractable, much more accessible to a broader swath of patients. And I think it's largely the short-acting psychedelics. So like 5-MeO DMT, like DMT, for example, where someone's in and out of a clinic in an hour or two. Or there's this exploration of, as they're called, non-psychedelic psychedelics. So I think the better way to think about it is way better microdoses. Like there's a lot of pharmacological limitations to just microdosing psilocybin or LSD. We're trying to engineer out some of the deleterious effects and make better microdoses, for lack of a better word. So it won't be perceptual. They're things that people can take for medical benefit and a lot more cost effective and accessible.
So you mentioned DMT. So DMT for which specific diagnosis? For depression?
Depression, yeah, is what people are largely exploring. But we can get into, there's some other indications, I'd say, even outside of CNS, which are interesting that we're
gonna get into that in a second.
All right. I won't jump ahead.
We know that psychedelics are kind of always been grouped with just mental health, but now there's so much more cool data coming out. So that seems to be the way that a lot of people are talking about it. We're just trying to sneak open that door, kind of get in that one diagnosis where there's a lot of data backing it up, and then find the perfect product that fits that niche, rather than kind of the other way. I just make a great product no matter what. It's not going to work in this setting, at least initially, until you guys kind of break the door down, and the FDA and the states have no choice. Which is probably coming, hopefully sooner than later, because the data just keeps coming and coming and coming, and it's really just frustrating. I know they're doing a VA study now, so hopefully that will let us into the government, hopefully accept it, because they're doing it they're doing it, they have to allow it. Otherwise, it's kind of counterintuitive, but that's a whole other conversation because they do it all the time. Anyway, so if you had to guess, as we finish up the kind of the mental health realm, when do you think it is going to be a pretty accepted routine part of the armamentarium for psychiatrists? 3 years, 5 years? Are we still going on that the marijuana thing? 20 years?
Yeah. It's a good question. Do I have to put money on this bet? Because then it changes that. Yeah.
No, totally free.
Yeah. Someone's going to watch this and hold me to account on it. Well, I'll first speak to kind of approval timelines. So when things will at least hit the market and psychiatrists can, the more pioneering psychiatrists or medical professionals, such as yourself, will be able to use these things. But so MAPS is advancing MDMA for PTSD. It's this organization called MAPS, which started as a nonprofit. They developed a for-profit arm to develop it, but they're they're going through the approval process right now with the FDA. So they wrapped up their phase 3 clinical trials. They've submitted what's called their new drug application to the FDA, and they're awaiting a decision. So that is pretty imminent that we will get a decision from the FDA. And if approved, which the data shows it is definitely efficacious and beats out placebo, if approved, that could hit the market in the next year on that one. There's a number of players advancing psilocybin, such as Compass Pathways, Usona, even a company called Cybin. Compass Pathways is in phase 3 clinical trials. So we're expecting 2025, 2026 that hits the market. I think when these kind of become like normal practice, like standard of care, that'll be a number of years. I think till, healthcare is notoriously sclerotic, and psychiatrists in particular are very sclerotic. So it'll take some time. But at least things will start hitting the market, and it will be an option for patients where patients can press on their medical professional that this would be something they'd like to use pretty soon.
I think we're finally starting. I agree with you until the last year or two. I think psychiatry was the oldest. I remember there were psychiatrists maybe 5 or 6 years ago saying SSRIs don't, which are like Prozac and Luvox, all those other things, and that they're not working. Patients don't have an SSRI deficiency, and they were castigated, they were banned, they were lost their license, and now people understand it more and more, and it's amazing how there's starting to be that shift. But in the psychiatric space, where it's not just about talk therapy and just doing those type of typical medicines, is now technology like transcranial stimulation and all that red light therapy and all these things that may help, and also using these other medications to hopefully get the patient better without having them have any major deficits from it. So I think we're starting to see now more of acceptance of those integrative psychiatrists, the word we're using now, which I really love, because I think the mental health crisis just is exponentially growing, and it needs to happen as soon as possible. And hopefully, I think this is going to hopefully be, again, the battleground that kind of brings everything down. So we talked. So as we mentioned a couple of times now, there's a lot of psychedelics are not just about mental health. There's studies that show how it can help boost immunity, help in autoimmune conditions. It can help as an anti-inflammatory. It can help energy. People are using it as potentially using it as an nootropic or an anti-aging device. So what is out there? What is the next thing that will be coming down the pipeline that's actually going to be usable to many people in terms of psychedelic space?
Yeah. So, I mean, I think I've beat a dead horse on the mental health application. So, depression, anxiety, PTSD, and then it falls under the umbrella of mental health, but it's always kind of surprising, addiction, like you're taking a drug to cure addiction to another drug. But we do see good data around psychedelics, psilocybin, for example, for treating alcohol use disorder. And then I hit on ibogaine, which is crazy effective for opioid use disorder, even though, ibogaine isn't a true psychedelic. But moving beyond that, I think you hit a bit on like neuropathic pain, headaches, stuff like that. That's a really interesting category. A lot of people who have cluster headaches and really have no options. I mean, triptans, or, when we're talking about migraines, triptans work for a certain percentage of patients, but there's a lot where they still don't work. And I'm kind of, migraine cluster are technically two different categories of patients, but, they rhyme to a degree. We're definitely seeing good efficacy around psychedelics for treating that, neuropathic pain more broadly. And then that's expanded. Some people have looked at things like fibromyalgia, you name it. I mean, we're getting definitely on the frontier where there needs to be more data, but you're seeing some pushes into those areas.
I think pathways in terms of working more on the neurotransmitters and decreasing inflammation, decreasing neuroinflammation, or are there other pathways that those are working on for those?
I think more inflammatory based, but I haven't dug like too much into the fibromyalgia one just because we haven't invested in anything in that. That's a tough category to go for, but But inflammation I like a lot. I think that's an interesting one. And what's interesting about that, it's not all psychedelics that seem to attenuate inflammation. So it's select ones like psilocybin, a lot of stuff that, it's not exactly mescaline, so it's called 2CB, or there's a lot of 2Cs. There's 2CI, 2CH, et cetera, it comes out of kind of the mescaline family. They're known as phenethylamines. Certain ones seem to be really good at attenuating inflammation as well. So one of our scientific advisors, Chuck Nichols, did pioneering research and made this discovery that they're able to really mitigate inflammation to a great degree, which I think is interesting. I think it's interesting for functional and integrative medicine because sometimes people refer to functional medicine doctors as inflammologists. Just like the moment you bring down systemic inflammation, a lot of things, the ship rights in terms of kind of health and illness in the body. So I think that's interesting. And then, you talked about cognitive enhancement. It's an area where juries still, there's different factions in the psychedelic space because we see increased BDNF, so brain-derived neurotrophic factor. So you can definitely measure that in plasma. We can see that, especially in animal models. With that said, there's a lot of drugs of abuse where you see increased BDNF and increased neuroplasticity, but there may be something to do with the brain regions that are getting engaged. Drugs of abuse are much more mesolimbic system, kind of primitive brain, where psychedelics, so the 2A receptor, the 5-HT2A receptor I hit on, is highly expressed in the prefrontal cortex. So it's a much more kind of executive region of the brain. You're not inducing addictive behavior by any means, but you may get neuroplasticity there where that could be actually an adaptive response. But there's a lot we still have to learn, but the data is interesting around that. And then that could bleed into neurodegeneration and things like that. But again, early days in terms of what we're exploring there.
And then so these are probably double digits from being actualized, from what it sounds like. And
yeah. I think in neurodegen, just like fibromyalgia, those are tough categories, but some people, at least we're seeing compelling data there. And last thing, I'll go on just another quick riff here. I mean, what's interesting is, so in a lot of models of depression, you see kind of atrophying of the neurons. So like if the neuron's like a tree, it kind of starts to wilt, and there's these things called dendritic spines. They're sort of like the branches going off. They're sort of wilting. And what we see in animal models, what's interesting, after administration of a psychedelic, you see the kind of these trees, the neurons return to a healthy state. The dendrites regrow, and they actually regrow into their old architecture often, which is interesting. It's not like a new branch grows. It's like the branch grows into the exact shape it used to be, which is, I think, fascinating in a lot of ways. So, we'll see what emerges there, but there does seem to be a compelling hypothesis around neuroplasticity, and the ability of psychedelics to induce that.
There's so much potential. I think I want it to happen faster because I see so much potential. But I think it's going to be, again, it's confounded by regulation, and it's just going to take time and time. So where are you guys now, besides mental health? Is the pain space where Palo Santo really thinks is the next big market to kind of grow, and those are the companies that you're looking for now? Or is there kind of a mix and match of other things as well?
Yeah, I'd say it's a mix of, we're definitely looking at some stuff around cluster headaches, migraines, you name it. I mean, a lot of psychedelics, they are promiscuous. So they hit like 5-HT1B, 5-HT1D, which is overlaps with triptans. But then you have the 2A mediated effect, which does seem to kind of attenuate migraines or cluster headaches. So a little bit of that. We do like the inflammation piece. So we have backed a company known as 2A Bio, and they are like the pioneers around the anti-inflammatory use cases for psychedelics, which could have applications in dermatology, could have applications even around ophthalmology, glaucoma, diabetic retinopathy, you name it. So those are some. And then I think back to kind of, where we're seeing the space head and the need to develop more commercially tractable psychedelics, there is this developing thesis around, non-perceptual psychedelics, like psychedelics where you don't have to take it, go on a big, long journey and, trip for 6 hours and everything, that at least there's all other tools in the arsenal where it could be like a microdose. It could be something taken daily where it isn't a hallucinogenic. And we've engineered out some of the other shortcomings of psychedelics, like there's cardiac effects and other things I can hit on later, which would have mental health applications, but really feel more like a microdose rather than like new ways to trip your balls off, basically, to use the medical term.
There you go. The medical term.
Yeah.
That seems to be the divine line too that I hear. There are patients who, or actually there's probably 3 buckets. There's people who wanted to help them medically. There are people who want the psychedelic and go to another space. And there's some people who want some type of overlapping Venn diagram there. So that, I think, is always going to be a very interesting combination there. Because again, you're not going to make everybody happy. And again, I think you're going to have, it's kind of like any other type of designer drug. You're going to have the medical grade, then you're going to have the people who kind of hopefully use it constructively. I don't know how to
hopefully, yeah.
What word to use there?
Sometimes escapist,
escapist. There you go. I don't say subversion, but we're going to use it. But
I think there's a spiritual component.
And I know very few people who, if they've done with either a doctor or a guide leader, have had a bad experience. They find it cathartic. They find new creativity, which is what I'm going to get into a second. There's other, their depression goes away. And the people use it for jet lag, which I find kind of a little bit a sledgehammer grasshopper type scenario. But people
use the first time I'm hearing it. I'm learning something new here.
They've used it because it kind of awakens, kind of resets the brain.
Yeah.
So it's kind of like hitting a reset button on an old school desktop. I think that's what's going to be so interesting is that, again, it's like any other business it will eventually be, is that you're going to have, again, the medical companies and kind of the companies and the tour groups and everything else that's going to kind of say, hey, this is more like Burning. This is, again, I call it a quote unquote Burning Man experience, even though I'll probably people throwing things at me for saying that. But I mean, again,
there's a lot of factions. Yeah.
There's a lot of factions in Burning Man. I understand that completely. And I'm not, everybody has a great experience there. Yeah. So I think it's going to be very interesting to see how this plays out. And can they all play, because everybody can kind of work together, which it seems like the groups are doing now, from like MAPS and Johns Hopkins and all those types. And I think there's a major group in Canada. They're all kind of working together, uniting, and to try to get things more mainstream, or they're going to eventually just kind of all split into their own little factions and to hit what suits them the best. Yeah. And then things may not work as well.
Yeah. And real quick, I think that's some of the frustration with the FDA approach is if you go the medical route, you need to have a pathology of some kind. You need to have a diagnosable mental illness, at least for that compound to be used on label. Now, just like with ketamine, we'll probably see ubiquitous off-label use, but companies can't say that. But we probably will see that. But I completely agree. I think there is a use case around spiritual exploration, personal benefit, and what I found is the ability to rewrite self-limiting narratives has been a really compelling, a way that I've utilized these in the past, even when I haven't been depressed. So, yeah.
I totally agree. So, but is the FDA, is it understood the FDA says, we want you to make a version that's not going to put somebody on a trip for 24 hours. It's going to be the best microdose, but kind of self-contained. Is that kind of where you already know it's overhanging your head if you want to go into that medical space? Is that pretty much one of the rules that you think is going to be there?
It's actually interesting. So if you had asked me in 2020, I would have been like, we were really uneasy on multiple fronts. And actually the space leapfrogged even faster than we anticipated of things like 5-MeO DMT, which comes from a toad venom. That's how it was discovered. Don't
a lot of things like Ibogaine,
yeah, I mean, they're all plant inspired, but who thought to smoke a toad venom?
I remember I had a patient in 18 tell me this. He's from Colorado and in California. I'm like, and he's like hundreds of us go. I'm like, excuse me?
Yeah.
And and I looked it up, and there's all this, again, even then there was data behind it. And now I'm like, okay. Now it just sounds normal to me. But if you tell anybody, people are doing things from like toad venom, they look at you like you have 5 heads without being on anything. So yeah, it's amazing now, again, things become mainstream. So
totally
continue talking about it now.
Yeah. So we didn't even expect, things like that, which some of the biggest companies in the psychedelic space are now developing that molecule, 5-MeO DMT. But in terms of how the FDA is viewing this, actually, they've been very accepting of these being hallucinogenic, albeit they've set up guardrails. So they have published guidance, which is actually encouraging. Like if the FDA isn't giving guidance on a therapeutic area, it means they don't care about it. Like they're not taking it seriously. The fact that they publish guidance, they're actually taking it quite seriously. The way, the way folks at the FDA are even talking about it, whether it's at conferences, you name it, is with a very open mind, which has surprised even us at Palo Santo, quite frankly. But when a drug gets approved, what they're definitely going to have is what's known as REMS. So it's a risk evaluation and mitigation strategy. And so you're going to need to have protocols. You'll have to have therapist training to administer these. There's going to be a lot of guardrails and requirements around how they're delivered. But assuming you have that in place and the FDA approves of your REMS strategy, they will be okay with it. And we're seeing a lot of that coming down the pike.
Like I mentioned, I know now they're doing the VA studies. They're starting to dip their toe in it.
Yeah.
So I think it's definitely coming down between that and what you said. And I think the states and the government, again, going back to the marijuana analogy, is they see dial signs in their head. Okay, we have taxes and registered. You have to register with the state.
Money talks.
Yeah, register with the state to be able to open sites. I think it's going to be again. I think when it happens, the door's going to just get broken down, and that'll be the end of it.
Big time. And actually, one other thing too, the FDA has given what's known as breakthrough therapy designation to quite a few psychedelics as well, which is kind of an acknowledgement that in this therapeutic area, there's a high unmet need, and the data we're currently seeing on this intervention so far is really, really compelling. And that's been the case for psilocybin, ketamine, you name it. So that's been interesting to see, like their kind of acknowledgement. And usually I like to rep on the FDA, but this is an area where I've given them credit. Like they've been responsive and they've moved fast so far.
That's why, and again, I agree. I love the same, but that's what I've heard from on both sides. So from financial people, the companies, doctors, they seem to kind of, you have to have it. It's one of those things where you're just going to have more data than you would for something else just to push them over the edge. But once they're there, I think it'll be fine.
Yeah.
So we talked about the medical stuff. Now we've kind of hit on it kind of a little bit here and there. There is a lot of benefit for people. We talk about people we know both health-wise and just life-wise that being relaxed or being creative or kind of separating, taking that moment to just go away and be on your own space is great for you. And that's where psychedelics come in. That will never be a medical diagnosis. Okay, this is going to help you just relax, or this is going to help you be creative. But that's where they have a huge niche as well. So I know you mentioned personally, so you want to do a little kind of a deeper narrative there in terms of where we go with that.
Yeah, I think they call it. There's a book, How to Change Your Mind by Michael Pollan, which was one of the books that really kickstarted, I think, this recent wave around psychedelics. And he talks about what's known as the betterment of well people. So not just like treating someone who's sick or has a diagnosable condition, but if you're well and want self-improvement or, like I mentioned, want to rewrite self-limiting narratives, things like that. I think we're seeing a big industry emerge around that. Again, in some of these jurisdictions where it's legal, but you're a little bit in the gray area. But people really pushing into that. You mentioned creativity. That is something I've always found interesting, and sometimes I hit on in discussions is like, we have a diagnosis around, not an inability to pay attention, like ADHD, but we don't, and we have medications for treating that, but we don't have something around like lack of creativity, for example, even though, like there probably is something there, like, taking something to kind of kickstart a creative process. And I think, of course, artists attest to it, you name it. I mean, great works of art, things like that come out of psychedelics. Who is it? The inventor of the PCR test as well. Like he attributes it to LSD.
I've never heard of that.
It was something like that. Yeah, like that. Even Steve Jobs taking LSD. They say that a lot of people who come with these new great ideas were on something that kind of put them in a different space to get there, to make that huge jump. Otherwise, they may not have ever gotten there. Yeah.
So
and I think it attests to kind of, the state the brain's in. I mean, one thing I didn't hit on earlier on the mechanism of action underlying these, but what we see is a shutting down of what's known as the default mode network, which is kind of like, it's the way to think about it is like the guard dog sort of that cordons off different areas of the brain, doesn't allow them to communicate. And what we see in MRI scans is when somebody takes a hallucinogenic psychedelic, high dose psychedelic, we see a shutting down of the default mode network, and regions of the brain that normally don't communicate start communicating. That's where we see this synesthesia, people saying they can like smell colors and stuff like that. But you can imagine, through that process, you're also exploring new pathways you normally wouldn't, which is a key part of the creative exercise. So I think that's certainly a compelling use case. But like you said in the beginning, this is all with the proviso of doing this under supervision, with a licensed therapist. I think that is all critically important to manage any of the risks.
This is not DIY. None of this is initially is that. It just doesn't work.
Yeah.
I've seen too many patients who've had bad experiences and either never want to do it again, or they have an altered state sometimes. So this is one of the things so we've talked a lot about different use cases, both traditional and medical and non-medical. Where have we hit on yet in terms of what people need to know about psychedelics? In terms of the lay person, I mean, they may say, wait, again, what have we hit on yet that people should know about psychedelics?
Yeah, I think, like in having these discussions, I'm a big proselytizer of psychedelics. I believe there's a tremendous amount of therapeutic benefit, but I do always get hesitant around like things taking on a panacea tone. Like nothing's ever that cool. There's always trade-offs in anything. And so I think people, need to be aware of the risks which isn't a reason, not to utilize psychedelics. It's just to know what the risks are, and there's ways to manage around it. So, I mean, the biggest one is we know you're in an altered state. You think and can say and do weird things, so having someone there to protect you during that experience, you don't want to drive, that the basics like that. But then, there does appear to be risk if someone has susceptibility for psychosis, if they are bipolar, schizophrenic. These are not substances that they should use. We have seen that trigger people back into psychosis. So that is a major weed out criteria in clinical studies and in use cases. And then I think the FDA's acknowledged this in their guidance. It's something we know, and this is part of why Palo Santo exists, is to invest in next generation psychedelics, more around microdosing. Like microdosing's all the rage right now. If you go to any bodega in New York, there's mushroom chocolates there. But there is cardiac risk, towards microdosing. So I hit on the 2A receptor, but psychedelics do hit other serotonin receptors, and one of them is what's known as the 5-HT2B receptor, which is highly expressed on the heart. And what we've seen is when you chronically activate that receptor, with other medications, people have developed valvuopathies. There was a drug known as fenfluramine, which is a weight loss drug, got pulled off the market.
Fen for people who don't know out there.
Fen, yep, for short. And so that got pulled off the market. And there are even kind of psychonauts, like the OGs in the space. Some of them, there's a guy known as Sasha Shulgin, who's sort of a clandestine chemist in the space. He did get a valve replacement later on. I mean, he did a lot of psychedelics. So we don't know whether that's attributable. So, around microdosing protocols, there's protocols like you definitely do 1 day on, 3 days off. Otherwise, you're going to develop tolerance. But usually the recommendation is after a few months of doing a microdosing protocol, you stop for some time out of abundance of caution. So there's just a lot we don't know there. In terms of what Palo Santo's investing in, we know some of that liability can be engineered out. So we're working on that, where you can completely cut out any activation of the 2B receptor. But in terms of the commonly known psychedelics, what a lot of people are using underground right now, there are those risks. And then with ibogaine as well, there's something known as hERG inhibition, which is also a cardiac risk. So a different channel, but can also, create some cardiac liability. So a lot of this can get engineered out. It's going to be a number of years until we get better medications, but I think they're important risks for people to know about.
Definitely. And for people who are looking into space, explain what microdosing is. Because people hear it's become a very, ubiquitous word with many definitions. So explain what people need to know in terms of what microdosing really means.
Yeah. Typically what it means is taking a dose that is low enough that it's known as what we call subperceptual. So you don't have any perceptual effects. You don't attest to an altered state of consciousness. Where it gets a little muddy is people speak to mood improvement and things like that. And it's like, are you mildly tripping? And so that's why your mood is better? Or are there other, channels getting hit, like in, anti-inflammatory channels where like tempering of inflammation, you're going to feel better and other things that make you feel better. We don't know, but technically it should be that you're taking a dose that is subperceptual, that you feel like you can go around your normal day, interact with people normally, you name it. One thing to keep in mind with microdosing is the reason why it's these 1 day off or 1 day on, 3 day off protocol, so you kind of microdose every 3 days, is because you do get rapid tolerance buildup with any of these agents. So if you were taking a psychedelic every day, you'd pretty quickly not respond to them. The pharmacology of the 2A receptor, there's intracellular pathways that currently get activated where you can't take it daily like that. It has to be intermittently. And some people try to cheat the system, but you can't do it this way where they're like, well, I'll do psilocybin 1 day, LSD the other day.
That's what I've heard. So it doesn't. Okay.
That doesn't work. Yeah. It's what's known as the beta arrestin pathway in the cell, basically leads to internalization of the 5-HT2A receptor and this tachyphylaxis, as we call it, this tolerance buildup. And there's cross tolerance across the molecule. So you can't cheat God, unfortunately, on this. Again, we do think there's a lot of this that can be engineered out. I mean, we're doing some really high science stuff and investing in cool companies that are like tinkering down to the level of the G protein and the beta arrestin within the cell. And there's ways to engage them and like an Emax below certain, like all this cool stuff where we probably won't get these effects. But as things stand now with like the psychedelics we know, what people tend to microdose like LSD and psilocybin, those are a lot of the parameters that they're working within.
I have to ask for everybody's going to be listening to this. So you have, again, for an investor, you have a very deep textbook knowledge of this stuff. So yeah, and I know you said you looked into it before. So just kind of did the the high school knowledge merged with the VC knowledge, and now it just kind of it matured into where you are now. It's just that you speak both sides of the language very well, and they've merged perfectly. But it's kind of interesting. You kind of the way you kind of hit one part. Oh, this is the investment part of it, and then okay, this is the microdosing guide part of it. So it's and you've merged into one.
I feel like I need to be the conductor a lot of times of like, there's a lot of different instruments in the orchestra that we need to like, there's a deep tech component. Like you need to know the science and what is actually going to make for a good product and, hit your desired disease target. But then like what makes commercial sense, there's a lot of pieces of the puzzle. I actually think it like starts with the two things. My grandma was a biology teacher, played a huge role in my upbringing. So we were always talking biology at the dinner table. And my great grandfather, Arthur Zintek, actually worked in Jonas Salk's lab, so in developing the polio vaccine. So it was always kind of like a big, that narrative and everything was a big part of my childhood, like this push towards science. My grandma, who was almost like a second mother to me, wanted me to become a doctor. But, my dad was in finance. I had the inevitable, I sold out on things, but my compromise was being, focused on healthcare. Yeah.
You may made the right decision at this point, but
I was a doctor. Yeah. You can tell me,
Well, as a doctor, you're an entrepreneur, and especially with longevity and anti-aging stuff. Again, I tell my patients, I'm a tour guide. It's because you have to explain them and then show them, okay, this is all that's out there, like you're doing. And then you may want column A, may want bucket B, and then you have to just figure out what you want to do.
Totally.
But thank you to all the high school biology, chemistry teachers out there. Otherwise, we would not have any of this stuff or any of the knowledge or passion for it. So thank you. I'll just put that out there because that's what inspired me to be a doctor. So definitely very cool. So where is Palo Santo heading in the future? Is it all, what's the next new, is there next new jaunt for Palo Santo? Is it all deeper dive into psychedelics and mental health?
I mean, we're all in on psychedelics. So 80% of our portfolio is focused on therapeutics. So it's kind of traditional FDA pathway for better, for worse. That's a lot of our focus. That's kind of where we can excel and as you've seen, where we have a deep knowledge and I just think an information edge around the pharmacology here. We will invest in some services, and I do think there's a tech enablement component, like even for the long form therapies where you're going to be tripping for 6 hours. There's probably a lot of tech enablement where you won't need as many practitioners in the room. You could do like a control room type thing where like multiple people in a room being watched, stuff like that. But within therapeutics, I think a lot of the focus is how do we make these more accessible, more affordable to a broad swath of patients. I don't think the like highly hallucinogenic experience that's never going to go away. Like there's always going to be a place for that.
Totally.
I can afford that. There's an upper 1 or small percent of people who can afford those, but they're expensive. The price tag on like Compass Pathways, who's advancing psilocybin for treatment-resistant depression, the estimates are that that'll be a $20,000 intervention, for example.
For how long?
It's a one-time administration. You have a lot of pre-integration and post-integration.
Okay, so one deal, no pun intended. Okay.
Yeah. But there's a lot of therapist time involved. That's kind of the main expense around these, but that's expensive. So, how can we engineer things where we optimize for a lot of variables, but one of them being commercial tractability, patient accessibility, where I have no doubt efficacy probably will come down a bit. I do think there's just a raw subjective component to these that is therapeutically beneficial beyond even the pharmacology. So you probably cut out that layer if people aren't having this big hallucinogenic experience, but a lot more people can afford that. Payers are willing to cover it. And unfortunately, something we face in psychiatry is just spend is very low for some reason, but payers just don't reimburse like they do in other therapeutic areas. It's frustrating. Hopefully the paradigm changes around that. But there's a little bit of kind of just seeing the world as it is and working within those parameters. So that's a lot of our focus, plus the new therapeutic areas we hit on, whether it's inflammation, neuropathic pain, other disease targets beyond even psychiatry, I think is interesting and important for us to maintain diversification, not all our eggs in one basket.
It'll help you and it'll help the products come to market, and it'll help the healthcare professional if there's an infrastructure. Because right now there is nothing. It's kind of Chicken Little, wrong analogy, but just kind of everybody just doing their own thing. And you need to have, if there's some type of automated thing, or I'm sure there'll be some AI part of this eventually. Probably. With it, like there is everything else. Like we were just talking, there'll be AI doctors, AI whatever.
AI venture capitalists.
There you go. You should just do this and that's it. You'll be done. You're a billionaire. So anyway, totally. This is the future. I appreciate you coming on. Let everybody know if they want to find information about you, the products, or you specifically, how do they get more information about what you guys are doing? And if I don't know if you guys are taking any more pitches, but I'll let you answer all those questions and how they can find out more about your investment company.
Yeah, for sure. So I think biggest thing, our website, palosanto.vc. We also, have some activity on social media as well, where we'll, pump out, just when I have media appearances, things like that, we're pumping out information. But that's where people can really, I think, find the main details on us. A lot of our information is on the website. So we're still investing right now. We have dry powder we're putting to work. If there's founders out there, we love to hear more pitches. We love this kind of high science, working on new chemical entities. But I'd say this, and then I'm on Twitter, Instagram, all those things if people want to follow it. But as you can tell, I have a passion for the space. We put out a lot of media and information on this stuff. And yeah, that's how you can find it. But palosanto.vc, just palosanto.vc is our website, and it's where a lot of it is.
Are you US based or totally international or both?
Largely US, a lot of Europe, though, a lot of UK, kind of anything that there's the FDA here, EMA in the EU is the regulatory agency.
More fun there, yeah.
Even more fun, right?
Yeah, exactly.
Yeah, albeit there's some ways actually in which they're more relaxed around like substance use disorders, which is interesting, but that would be a whole different podcast. But that's like more liberal, surprisingly. But active there, and then a little bit of Canada as well. But those are kind of the core markets we look at. So we don't dabble in gray area stuff, for better or for worse. It's just legally tough. So even stuff cropping up in Colorado and Oregon, we can't touch right now, unfortunately, or stuff internationally. Like if it's a clinic in Mexico or Jamaica, we can't touch it. I fully support it, just doesn't fall within our mandate. But a lot of the biotech oriented stuff or the services and tech pieces we like looking at. So
perfect. I appreciate you coming on. Definitely check their site out and stay tuned for the next episode of the Life Optimized podcast. We'd love for you guys to hop on. We'll put the show notes down. We'll put the link to Palo Santo, and any questions or comments, we'll answer as best as we can. And if I need to, we'll link him back up, see if we have to link any companies or pitches or grow the space as much as we can. But thanks, and we'll see you guys soon. Bye-bye.